Scott Marquardt from the Blind and Broadband Strategy Board, and I'm honored to be the room host for this incredible session. Bios for our panel are on page 24. Certainly won't read them all, but we've got Mary Devaney, Lisa Wall, and Marcia Wayne here to tell you everything you need to know about telehealth, rural healthcare, and what it all means for all of us in communities. I'll turn it over to Mary. There will be some time allowed at the end for questions. If you have a burning, clarifying question, during the meantime, they'll certainly take a clarifying one, but we're going to allow a little runway at the end for questions. So please help me welcome Mary.
Great, thank you. Yeah, we're going to cover everything you need to know in 45 minutes. So, batten down the hatches. Here we go. No, I'm going to just give you a little bit of an overview quickly. But I'm initially going to tell you about the organization that I am with. So while we're going to talk about telehealth and the importance of that last mile, one of the things that I bring to the conversation is about the telehealth resource centers. So I represent the Great Plains Telehealth Resource and Assistance Center. That, since it's so long, we shortened that down to GP Track. And we are one of 14 telehealth resource centers across the country. There are regional centers, we cover all 50 states, and then there are 2 additional topical centers that focus on telehealth policy and regulation, and then the other one focuses on technology. And we are federally funded, we are federally designated, and we are, for the most part, free services. There's resources online at each of us. Let's see, the website is across the top. If you go to that website, you can get to all of the resource centers. Or if you go to the gptrack.org, on the bottom side there, you can get to not only GP Track, but all of the other ones as well. We've intertwined ourselves, we're much more of a collaborative. And so just to kind of bring you up to speed as to what GP Track does, as I mentioned, we have a lot of resources. We have a lot of contacts across the country. So if by chance you're looking at figuring out how to do a certain aspect of telehealth, we are able to reach out to communities and organizations across the country and find you a match, find you a person that is either is doing or can certainly provide some insight about how to do that particular type of telehealth for you. Also, we have an annual conference that you may want to at least become aware of. That is an opportunity to come and learn about what everybody else is doing around our region. So our region includes North Dakota, South Dakota, Nebraska, Minnesota, Iowa, and Wisconsin. And this is a regional opportunity to learn kind of what your neighbors are doing and what kind of things, what kind of ideas you can bring back to your own community. So to kind of level set us here a little bit, we know that there's a lot of different words. When you think about telehealth, there's all sorts of different types of words being utilized. Telehealth, telemedicine, virtual care, e-care, mobile health. All of those are really part of that term telehealth. And these are really kind of, it's kind of a word salad because there's also other words, digital health. There's virtual care. I mean, anything that is kind of the trick or the word of the day, so to speak, is really all encompassing under the umbrella of telehealth. So when we think of telehealth, it's basically the remote delivery of healthcare services and clinical information using telecommunications technology. So it's very broad. It's very broad, and it includes things like telemedicine, which is the more clinically focused, remote patient monitoring, which is the modality that monitors physiology and behavior to maintain an individual's best function. And that is primarily, and I shouldn't say primarily, often used in a patient's home. And that's why I wanted to raise that up and what we're here to kind of discuss. So this is a wide puzzle collage of all the aspects of, or many of the aspects of telehealth. And I think the piece that is of most interest to all of us, or certainly the one that is growing in interest for us, is this piece right here. And that is the piece that is consumer-based, consumer-driven, consumer-focused, and home-based or mobile-based, wherever that patient or client happens to be. So up to this point, really, telehealth, telemedicine, has really been facility-based. It's been from the perspective of a large hospital to a rural hospital or clinic, or rural hospital to rural clinic, or clinic to hospital, or clinic to school to hospital. It's been primarily a facility-based operation. What we're starting to see now, and what we're going to talk a lot about here today, is that is changing to home-based. And it's from two different perspectives that you're going to hear of from today. It's not only from the patient's perspective, but also from the provider's perspective. And so to start us off, I'm going to turn to Marsha Wayne from All True Health, and she's going to discuss a little bit about the patient perspective.
Thanks, Mary. Good afternoon. All True Health System is in Grand Forks, North Dakota, but we serve North Dakota and Minnesota. We've been doing telemedicine, telehealth as such, for about 13 years. And our goal really is to draw our patients closer and provide that health care where they want it. So this is the map there. You can see our telehealth sites. So these are like Mary said, this is telemedicine where we connect to facilities. Hospitals, nursing home, residential centers, etc. And that's pretty much our catchment area. So we have that many rural sites that we connect to over the internet, low tech kind of. And then on the chart on the top, we do about 11,000 visits a year. This is patient to provider, billable encounters, business people. Healthcare is a business. We work very hard to make sure that all of these are covered. And we were named the North Dakota Rural Health Program in 2018. So telemedicine, like Mary said, we can put this in any clinic space. We have very small clinics. We have about 10 rural clinics across North Dakota, Minnesota. And we have a cadre of specialty services as a tertiary care center in Grand Forks that we provide out to the rural area. And we depend on that regional aspect of care. And all of those service providers in those specialty areas want to keep those patients local and at home if possible, but definitely in those rural clinics. And our providers sit in their offices in Grand Forks or at the other rural spaces. However, the day has come. It came a little bit faster than I thought, actually. But we talk about virtual care of connecting to the patient wherever they are. Not necessarily at home, but on their phone. And you depend on everything in that computer in your pocket. And as a healthcare provider, we do too. We want to reach you wherever you want to be reached. We make appointments on there. We keep your health record on there. You can change appointments. You can talk to your doc. You can send messages. You can have an e-chat. You can have a video visit. You can get cost estimates. You can pay your bill. So we really want all of our patients to have that app on their phone and be connected to their health care and carry it with them. And I just had to add an accurate vaccination list for those moms that, when you're always looking for that accurate list full time, right? So it's very, very important. This is an app that's connected to our electronic medical record. And if you don't have one, you should talk to your clinic tomorrow. Tomorrow? So when we talk about connected care, there are tools. That's a scale and the blood pressure cuff. They're Bluetooth connected, again, back to my EMR app, and all of that information is constantly sent to my doc. The days are over that you need to walk in the clinic and have your blood pressure taken, folks. And you shouldn't do that. You should constantly be sending that information back and forth. Now, I can't do that if I don't have any internet service, right? So we have to be connected. It's just part of who we are. And it's very important whether at home, work, or school. And I was in the education session this morning. We reach out to schools all the time. So I have 130, 140 physicians, NPs, PAs. It's not unusual. In fact, one called last week and said, I have a kid, psychiatrist, I have a child, patient of mine. I need to be in that school conference next week, get me connected. That's not always an easy thing to do, by the way, in the healthcare world with regulations and whatnot. But those education tech folks, I call and say, hi, you don't know me, I'm from the hospital here, and I have a physician who wants to connect with the service providers in the local school, and can you work with me? And they do. A young child with diabetes, we can talk to the school cook, we can talk to the gym teacher and the classroom teacher, and it's a very, very neat thing that can happen in very, very rural schools, and it should. And that's what a video visit looks like on your phone. You're a sick kid, 40 miles away from any provider, and they want an answer, and that mom and that dad want to stay on the farm, and you want them there too. This is the way care can be provided and the way it should be provided. Just wanted to give you a little picture there. And the reason that we want to do it is because I have their EMR up. I have all of their medical history. I have the stuff behind how that child is functioning. So we provide better care than anybody else. Okay, Mary talked about remote monitoring. And remote monitoring typically happens in the home. And there's a tablet or a device that's connected to a healthcare provider. So we risk stratify patients, and it's typically those that have just come out of the hospital. And if you think of your elderly in a rural community, congestive heart failure, COPD, maybe high blood pressure, significant problems typically, that we want to check on them. So once a day, they get an alert, they walk over and they sit in the chair, put the blood pressure cuff on, or they step on the scale. And the beautiful thing about this is that it's sent to a nurse practitioner or a nurse or a doctor's office that's watching this. And on Wednesday, Annie doesn't look so good. I can tell by this. She needs a visit. And if she isn't taken care of, she's going to end up back in the hospital. So if that's your mom and dad that really wants to stay home and wants to just be cared for, and you don't have to worry about it, isn't that what you'd want to have happen? We have about 75 of these units out. They're supported either by a physician's office specifically, like cardiology, or home health, etc. Medicare is starting to pay for this, and you're going to see more of this. Again, internet service to the home is a challenge. We have all kinds of different ways. They carry a variety of hotspots to see if they can connect to this service provider or that service provider, whatever. So it's very important that the service be available. So this is kind of a good example of putting together all of the things I just talked about. So OB care. We have, 10 OB physicians, and they travel the regions. So they go out to all of these different communities to see patients, but babies are primarily delivered in Grand Forks. So we have moms traveling 2 to 3 hours, 4 hours maybe, to get that baby delivered. And if you're that husband, or maybe you're the business owner, that woman says, yeah, meet there, gotta go to the doc again. It's a 10-minute visit, but it takes me 3 hours to get there and 2 hours to get back, so I have to be gone. So we sat down with the OB and said, tell us how we can support your patients. We can keep them at home, we can keep them healthy, and keep them engaged in their health care. So one option is telemedicine. So if it's determined that certain weeks they go into a facility and they're supported by a nurse to give specific ultrasound readings, maybe to the doc, we can do that. There's other weeks that physician identified, we can just do this on the phone. So I'm going to send a specific questionnaire to them, and they're going to tell me how they're doing, see how they're doing, whatever. So we do it that way. And otherwise, there's an actual video visit. If I need to see them, if we need to talk about something, we can do that. And that's a kind of a comprehensive way to take care of patients. Again, mostly done on the phone, really. We have patients that take their 15-minute break and they go out to their truck, close the door, and they see their doctor. So it's good for them, and it's good for you, the business people, and it's good for the community. So the reason I show this slide is that I think that we, up in North Dakota, are in kind of a different area. Grand Forks is kind of in the middle there, and those 13 hospitals are small community hospitals with an average census of 1 to 5, very small. Most of our hospitals up in that area are community owned. They really are not aligned with the larger health system. However, all those in yellow, through a federal government relaxation of the STAR clause, we host their electronic medical record on our platform. And so again, it was a beautiful thing for that small community hospital to get tech support, to get a robust electronic medical record, and be tied into a larger system without obligation. Can I say that? However, think of the bandwidth needed to reach out to these facilities and support them. And in the telemedicine world, video is a very fragile thing. So one of these facilities with probably not a real good bandwidth drops a CT exam, which has a lot of information going back. The first thing that falls off is my telemedicine visit. So it's a very tenuous thing, but very good. So what is the face of rural healthcare? And I don't know if you just saw, SAMS announced that they're entering the primary care space in 3 states. Came out today. We really do not want that to be the face of rural healthcare. Is it wonderful? Yeah, it is. However, hospitals like mine can have their doctors see their own patients if we have the bandwidth to do it. And it really is coming about. So it's about providing the care where they want it, when they want it, how they want it, because they want to stay where they want to stay at home in the rural areas.
Thanks, Marcia. Next, I'm going to turn to Lisa Wall. She's with Alina Health, and she's going to talk a little bit about the need for telehealth from the provider's perspective. So I'll turn to Lisa.
So yes, I'm from Alina Health. We're a very large system based in Minneapolis. So we have a little bit of a different perspective than, say, Altru does, though Altru, when I first started doing telemedicine, Marcia was kind of my hero, hearing how to swap an in-person visit to a telemedicine visit during terrible snowstorms, which I think is kind of the perfect use of telemedicine. So first off, I just wanted to level set, because I'm a little bit new to broadband and to network. I had kind of a crash course recently with a new project I took on, especially from the provider end. So, of course, 25 megabits per second is kind of how we define broadband. That is the very lowest speed that we can do a telemedicine visit from. And with that, and we have an EHR open, we have, like she said, we got a CT downloading, we're gonna have problems. So, talking about the different ways that we access, especially for our physicians at home, that's what I'm talking about today, all the different ways that we can meet. And for us, sometimes that digital DSL works okay, but I do have physicians living in rural Minnesota who want to stay there. They're retiring out there, they have great lives out there. They want to get out of the city, so they're out there trying to practice medicine. So in my research, this is kind of what I came up with. I think I saw some people had this out on their desk too. But this is what Minnesota looks like right now. The yellow is where we actually have at least 25 megabits per second download speed. All that white, we don't. Those are areas that we can't reach with telemedicine. So that was on the Minnesota wireline information. I went out and looked at what the FCC's got, so this was the map that the FCC provided for me. gives us a little different picture, but one of the things that I really like is up there in the very top corner where North Dakota meets Minnesota, there's a bright yellow county. That bright yellow county, only 2.8% of the population has 25 megabytes download speed. And so I find it very interesting that we have those lines out there. So, a little bit more information about my physicians. Fewer than 10% of physician practice in rural communities, where 25% of our population lives. Here's how that translates. That rural physician is responsible for over 2,000 patients. So, my example here of my current physician group that I'm working with. Back in 2017, we have a rural hospital in Wisconsin, and they lost their hospitalist coverage. Those primary care physicians in the clinic decided they didn't want to do overnight coverage anymore, so they were scrambling. The way that we fixed that was we brought in a group called Eagle Telemedicine to quickly cover that hospital on overnight coverage. In just this last early September, Alina took over that service. So we're providing that service now to our own hospitals. We have 3 hospitals that we provide that service to. Okay. Thank you. Hospitalist service. So this is an internal medicine physician who only sees patients in the hospital. Typically, in our big city hospitals, there's a good handful of them covering those patients. And they're on usually for about a week straight, so they have that continuum of care. But in the rural hospitals, that's your clinic physician, quickly running to do rounds in the morning to make sure those patients are covered. And at night, those physicians are typically sleeping. So if the nurse needs something, she's got to wake somebody up. Typically, there's an ED physician, of course, in the hospital, and they are there to cover emergent rapid responses, patients crumping, code blues, that kind of thing. So now we have our physicians covering from their homes. And this is kind of a game changer for Alina. So our physicians are sitting at home. They're covering 3 hospitals right now, soon to be 6, though we'll probably be adding extra coverage, extra physicians to do that. But so they are at home, they have an Alina computer, they have EHR access, they've got access to the radiology software, and they've got video. And so they're sitting there awake all night, making sure that they can cover those nurses and any issues that come up in the hospital. So one of the benefits for our nurses, they loved when this came up because they no longer need to wake up a physician. Those patients can have their needs covered much more quickly. They don't need to stack, wait, until 4 different patients want Tylenol or need some sort of comfort care. They can get that very quickly. Like I say, the patient's needs are addressed very quickly. Patients get to remain close to home. When we started losing some of that coverage overnight, we were transferring more patients to the cities instead of letting them stay in their rural communities. And then now it is allowing our physicians better work-life balance. So those rural physicians now, they actually get time off. They don't need to be on call 24/7 anymore. So I want to talk about how we actually provide that service. So this is probably, most of you don't see what it looks like to get telemedicine in the hospital, but this is a telemedicine cart. It has a 30-time optical zoom camera that's very color accurate. The physicians can move this camera on their own. They can check a patient's pupils. They can do a full neurological exam. They can do skin checks. They can do wound checks and trust that that color is accurate. We have a nice large monitor for our patients to be able to see that physician. We have a wired speaker microphone that can move closer to the patient for those patients who are suffering from aphasia or hearing loss. And we run it on a wireless PC. That just allows us to move that cart wherever we need it to move in the hospital. And then we have this lovely kind of aluminum cart. But all of this is really important. Other things we have on this cart is we have a stethoscope. So that physician sitting at home can hear those heart, lung, and abdominal sounds. And one of the things that we do is we put a higher-end camera on our carts so that we don't need to take a nurse off the floor when she's busy to help do that exam. That physician can move that camera around and do the exam that he needs to do, So as I started doing this project, I ran into physicians at home. So we sent them home with kind of a package of equipment. They got a laptop, they got a big monitor, headset, all of that thing. We're told, go ahead and hook it together. No help at home, of course. It's kind of like a puzzle. And then hook it up to their network and see what happens. I had somebody who had 3 megabits download speed. We can't do it. We can't do anything with that. I have another physician that's out in Wisconsin. She barely can do a visit because that's the only access she has. She has 25 megapixels. So she's got to be careful. She can't open up several things while she's trying to see that patient. It's pretty much what we're experiencing out there. We want our physicians to have a better life, better work-life balance, better quality of life, and allow them to work in our rural communities. And broadband is really what's going to enable them to do that.
Great, thanks, Lisa. So you've kind of seen, Lisa kind of had shared a little bit about kind of the that large, the large system, the large technology, and the value and importance of having that broadband connection for the physician at home to allow for that work-life balance, and also to allow for that support of that remote location. Whether that location actually is urban or rural-based. The physicians can certainly be supporting some of those urban-based services from home as well, but obviously from the perspective of rural, that's a bigger, sometimes a bigger hill to climb from the perspective of connectivity. As we talked with Marcia, it's a lower technology. It's maybe not always the large cart. Sometimes it is a technology that's is maybe only video is required, or maybe it's the EHR and the components and the video links through that. So there's a variety of aspects of this, and the core of this all really comes down to how do we support providers, patients, and communities to really be able to build the services that they need to have to support those people that choose to live where they do, whether that's urban or rural, or very rural or frontier. So what we, let's see, where's that? Here we go. So just kind of a little bit of, this is some of the citations I know from Lisa's. And we are at the point now where we can have some questions kind of from the audience. We have some in our own heads that we can feed, but I know we've got some questions from the group. I see a hand that's kind of sort of, yes?
I just have a quick question. I'm sorry, I missed your name.
Lisa?
Lisa, you said that 25.3 is the minimum required both on the remote physician and patient end. Do you know what you actually need, or have you studied that at all?
So
There you go.
that's one of the things I've been trying to figure out, because it varies quite a bit. And I don't know, as you guys know probably, that what package you purchase from your ISP isn't always what's coming into your home, right? So we say 25, but we don't know that they're always getting 25. Say it's 3 o'clock in the afternoon, the kids are home, they're all gaming and doing all those things, and it's starting to constrict into that neighborhood. But yeah, that's one of the things I'm trying to better understand so that I can better guide my physicians too.
Over here, is it a question? Oh, yes, yes. I'm sorry, I can't see you with the sun.
So my wife is a rural family practice doctor, and she delivers probably over half the babies in our community. So I'm extra tuned into that issue. Now, telemedicine is great for a lot of stuff. You know, any application of telemedicine for the actual baby delivery, because rural centric and particularly the ability to deliver babies is critically important to the community. We almost lost that program in our hospital once, and only from public outcry did it hang on. It was only by the
I think that part of it is around how do we support the providers that are in those communities to assist them to be comfortable in the services they're delivering. And this would be part of that, certainly. So, Marcia, I think you've got some things?
I was just gonna say, due to the risk of OB, of course, that is a tougher question, but I know within Alina, we partner with Children's Hospital, and they do have a neonatal program where when there is a problem delivery, they can get a children's neonatologist on the video very quickly.
So that's a great point, because the main reason it's so hard to get the doctors to cover it is they don't do enough, well, never mind the insurance liability, emotional impact, they don't do enough of it to feel comfortable with the skill set. So having seen doctors that have been hesitant to, rural doctors who have been hesitant to do OB, now be willing to do OB thanks to this backstop.
You know, that's a really good question. A lot of what I was reading going into this was talking about the rural physicians and needing that support of specialists to feel confident to practice medicine in rural communities, and that's kind of one of the things that Alina tries to do. But like I said, I'm gonna let Marcia answer that, but OB is a tough one.
We have those small hospitals around us, you know. They're primarily staffed by NPs, nurse practitioners, at night especially. And Grand Forks is the home of the University of North Dakota, which includes a medical school. And it's an ongoing conversation about why are we not sending more physicians out to the rural area? They just do not want to be there. I mean, it's a tough gig, high risk, and there just isn't enough support. We also, we have a NICU program. We have 4 dedicated NICU docs, and we had talking about nighttime coverage. No doc wants to do nighttime coverage anymore. I mean, they're coming out of school saying, I'm not going to work at nights. It's like, well, who do you think he is, you know? And so we're always talking about this nighttime care. And we're a Mayo affiliate, and we spoke with Mayo about their NICU program. So there are those NICU programs out there. That program is really designed for a small hospital, primarily intubation. So not breathing well, have to intubate the baby, and you package them and ship them. You know, I mean, it's not meant to have ongoing care, and that's typically what a lot of telemedicine emergency is that stat assessment, package them and get them out of there. So kudos to your wife, and I hope you stay there. I mean, it's really tough. Really in all of that region, there's 3 other facilities that deliver babies in the rural area, and if it's anywhere near high risk, that mom is not invited to deliver there. So it's tough. But there is some. I mean, it's an oversight situation, probably, you know, not what your wife is looking for. And I'll tell you what I tell my docs. We orient all the physicians that come into Altru, and the message is, welcome, we're glad you're here, because it's hard to get a doc to come to rural, and we are considered kind of rural, believe it or not. This is how we deliver care. And we go through the spiel, and the next question is, how do you see this working in your practice? Because that's how it works. And sometimes they're surprised, and sometimes it's like, oh yeah, okay, I'll think about it. And sometimes, oh yeah, I've done that before. I know how that works. So.
Yeah, I think when you think too, there are programs out there too that are supporting the high-risk pregnancies, and they do the OB ultrasounds through the system, through the technology, to again support that patient in their home community. But it's not OB and support of that and actual telehealth services that are specific to that are slim. Oh, question up here. Yes.
So this is for Marcia. Marcia, you were talking earlier about when you were into your My Health or your My Chart system. When your individuals are going into their, if it's a parent, if it's a patient themselves, it's going in and pinging their physician and asking questions. How is your billing? How is your reimbursement for that? And are they being reimbursed for that? Because your RDUs are based on physician time. So.
Yep.
Great.
Yep.
Thank you.
Thank you. So the question is when you go to that app on my phone and I connect with the physician, I get a medical service, are we being paid? And we are. Both North Dakota and Minnesota has parity, and if you're providing the same level of service, it's paid if you connect to the home. Medical assistance, most of your commercials. The kicker, you can all vote on this soon, if you can get it there, is Medicare. Medicare won't pay if you connect to the home. Medicare, we have to ask those people to go to a medical facility, and then it will be paid. But it's a big point. It is reality of life, is it not? Right? So I'll just share a little bit too much information. You know, being the telemedicine person, right? A while back, I came home on a Friday, take my work clothes off or whatever, and I had an itch or whatever, and realized I had shingles. And I'd had them before, and I knew what it was, and I just thought, I wonder. And I pulled out my phone, and I got my app up, and by golly, my e-visit app said shingles. Cool. So by this time, it's about 6 o'clock, you know, and I put in the stuff, you answer the question or whatnot, sent it off, it goes to the urgent care doc, and he said, you know, I sent a picture with, I got to send 2 photos. I took my ugly 2 photos, right? Sent it with, about 20 minutes later, he asked me a question. You know, you had this person once, I know he asked what he was supposed to ask. And apparently I was eating dinner or whatever, by golly, he called me, called the home phone, he said, you know, I'm concerned, the pharmacy's gonna close at 8, and you need to have these meds right away, and, you know, is this bad? And I said, yep, answer the questions. And I had meds by 8:30. And in the shingles world, that's a big deal, by the way. Big deal, because it really cuts down. That's the way short, $20, $20 copay. A lot cheaper than going to urgent care in the ER, right? Which I probably would have done on Saturday if it would have moved a little bit more. That's the way healthcare should work. For all of us, everywhere.
How does it work when you need to layer in a language barrier? You know, certainly, obviously, there's a lot of folks that are, you know, speak Spanish in healthcare settings, but in, you know, especially I live in Southwest Minnesota, you know, Somali, Chuukese, a lot of languages that are hard enough to find in professional services. How do you layer that in not only for dignity and caring, but liability and everything that's, is that even realistic? Or,
Yep.
Okay.
Yep, it's responsibility. When we provide telemedicine or telehealth, we have to provide it to the same level as you do in person. So we have to figure that out. And there's either an application where our language interpreters just come in to the video visit and is a part of it. We're kind of low tech and we get them on the phone and because that's how they do it. Do you do that too? That makes me feel better.
We have the Marty card, which is what the telehealth or the interpreter services is, so you should call the Marty card. We have that card facing our telemedicine card,
And it goes.
we do it.
Have to. It works very well.
So you and the patient and the interpreter are all,
And the doc
and the doc are all interfacing
at the same time.
simultaneously. Okay. Wow.
Good question.
Yep, take it on to one.
Any other question from the, whoever got the second? Go ahead.
To your point about Medicare not being a player in this space right now, you know, not asking you to go against your company policies of advocacy, but is there something we could do as a broader community? Is there an organization that's trying to change that? Somebody we should support? Sign on a letter to the, you know, a letter? Who's monitoring that, and how could we help as a community of people who care about this? Or is no one fighting that battle?
I have to back away from
Yeah.
Okay.
You know, there is.
I don't think you're being recorded, so.
Yeah. There is a national Connected Care, is that right? And they're the policy-making group for telemedicine,
Not policy made,
not policy,
following.
Yeah.
They interpret and communicate what is going on from the policy world from telehealth. So since we're federally funded, that's why it gets a little sticky from my perspective. But organizationally, across the healthcare systems and such, they are certainly following that because it impacts them daily. It impacts them, if they can adjust the reimbursement picture as it is today. Medicare is the most restrained at this point. You can still get reimbursed for a lot of things in telehealth. and telemedicine in Medicare, but it is certainly the piece that is probably needing the most shifting to make it a little more broad and a little more doable. Medicaid in each state, of course, is unique to that state. And then you have each of the payer groups across the region, and sometimes they will have their own little tweaks. What's happening is, as Marcia mentioned, is states are passing what's called telehealth parity, so that really requires insurance providers to pay as if that is an in-person event, if the service is the same. And so it is shifting, it is coming around. We're starting to, also organizations are needing to think more broadly than just the video aspect of things that we've kind of highlighted, certainly video, but remote monitoring, chronic care management is really the piece that often the remote monitoring falls under. And that's often defined outside of telehealth, at least from Medicare's perspective, which is confusing but positive because it allows us to not define it as telehealth or telemedicine, because that then requires it to be done only in a rural location, in a hospital or in a clinic. So it allows it to be separated kind of from that regulatory burden, and allows it to be reimbursed in a different manner. Is that kind of?
Yeah, thank you.
Okay.
Did you say that Minnesota does require parity?
Mm-hmm.
Yes.
Yes.
Yes, Minnesota, of course, is always just that one step better.
They require coverage and payment parity. So they ask the commercials to cover it, and they're gonna pay it at the same dollar amount. North Dakota, we're gonna require them to cover it. And luckily, they're paying it at the same amount currently, so we're good. But
How long has that been true in Minnesota?
about a year and a half, yeah.
So I'm guessing that the rural clinics and hospitals and stuff are possibly still catching up to being able to have the service to do the telemedicine now.
Yep. You will all, I'm gonna say this, that it isn't about the tech anymore. You know what it's about? It's about finding the provider that'll do it. And I think that is, my flag will come out shortly, like I said, is that these providers, that's how people need their care, that's how they want it, and that's how they're gonna find it. They're either gonna find it from us, or they're gonna find it from CVS or Walmart or whatever. So, we need to bring our providers along and show them how easy it is, and to provide that redundancy and that consistency and that, right?
Correct. And, I have noticed as I've been training physicians that it takes a lot of creativity on their part. And it does, because they need to rethink how they're going to do that patient exam. We can give them a tool, we know that they can do it, but they need to rethink how they do that and how they use the staff at the bedside to do that exam and how they evaluate that patient. But we even do code blues and rapid responses with our telehospitalist program, so the work can be done.
And it's very high quality, and it gets quicker to the bedside. It improves care. We've got the studies, there's all kinds of things we can show you. Here's your homework. Just go home and ask your doc. Can I connect you? If I have a problem, how can I connect you? Can I send you a message through my chart? Will you take a video call? Because these physicians, the one thing they say is, I'm tired of everybody messaging them. I'm tired of, I don't want to answer phone calls. And if we can get to this virtual means, it is reimbursed. Not very much, but it's reimbursed more than the phone call is. And the second thing is, it is captured in my chart. So if I do end up going to my family practice doc, my PCP, or into the ER, it says, oh, I see that you had an e-visit for your shingles. Now they're infected and you have a problem. Yep, and they can see exactly what kind of care it was and what was prescribed, etc. That's better care. But they have to be connected to the internet. So that's the other thing you can do.
As we talk about at the bedside, that bedside is moving home. And I think that's a piece that we need, as Marcia described so well, a thing that we need to kind of be thinking through about that last mile. That last mile is, so I live just outside of Sioux Falls, and up until, I think it was about a year ago, I had fiber running down the ditch. I live in a small rural development outside of Sioux Falls, and that fiber was running right down the ditch, and I couldn't get to it. So I had terrible download and upload speeds. Fortunately, we've resolved that in the last year, but that's the last year. And I live in the, just outside the biggest community in our state. So it is something that is still, needs attention, and especially when you think about, so I grew up in a farm north of Vermillion. We can't get nothing out there. We don't have, we've got a quarter-mile drive. We can't get dish speed. We can't get anything out there. So it is still an issue. It's still something that we need to be paying attention to, and that last mile is really critical. So thank you today. If there's any other questions, please feel free to come up, but we are at the end of our time, and I'll turn it back to Scott.
Thank you. That was fabulous. Next session starts at 2:30, so you have a break. Thank you all.